Karen. I'm really thrilled to be here today, and I'd like to make a kind of contrarian suggestion that, in fact, we look to translational research as a methodology to use to demonstrate the impact of credentialing, nurse credentialing, but as we move to interprofessional teams in the acute care setting, and in ambulatory care, which is my area of expertise, it's very difficult to parse out the absolute contribution of nurses versus others that are working in the same environment with the same patient population. And so let me share a little bit of why I'm saying this. In my post-Dean experience, I got back into evidence-based practice and discovered translational research, and that was about 7 years ago, and I had found my home. I love translational research. I think it is the answer to robust data sets and reliable data sets, because if you, in fact, take and put into place evidence-based protocols, if you take and you code indicators in standardized language so that you can, in fact, track assessments, interventions or processes, and outcomes, that standardized language becomes your data dictionary and provides for you a robust methodology for looking at what nurses are doing. But in fact, I discovered, because my translational research project has been to work with colleagues Dr. Beth Ann Swan and Tracy Haynes to develop the care coordination and transition management dimensions and competencies. Initially, we thought we were developing it for ambulatory nurses, but what in fact we've discovered in the process of developing it is you can't limit, these are not limited to ambulatory nurses. They can be done by acute care nurses, they can be done in skilled care, and so they are, because they came from an interprofessional or an interdisciplinary literature that wasn't limited to nursing and wasn't limited to ambulatory care, they go across the board. So this has been 2 years of discovery for me, and what you're going to see in what I'm presenting has to do with that discovery and the question of how can we do research that demonstrate, I would say, nursing's contribution. I am concerned that we talk about causality, but it's difficult to talk about causality if you have multiple different providers working in the same area. And we know this is true because there is overlap in scopes of practice for different professions. And it really shows up in ambulatory, but as we move to, the other thing I do besides doing the research, I facilitated at Northwestern Memorial Hospital with staff nurses at the university, at the unit level, doing translational research. And as we move to interprofessional rounding and huddles in the acute care setting, the issue is the same. We have multiple different professionals providing care that in many places there is an overlap. So I'm going to do a little bit of talk about translational science, then move into translational research. And translational science is all about investigation of methods, interventions, and variables that influence adoption. And it's all about adoption in healthcare. We have gone through all kinds of bandwagon projects that we put into place. They may be adopted. If there isn't a maven taking care of them, they fall by the wayside. What we want with best evidence-based practice is for it to continue and to be sustained over time and updated as there are changes in the research database for it. This adoption by individuals and organizations should improve clinical and operational decision-making in healthcare. And the empirical foundation for translational science is evolving, and it's evolving if, in fact, we do code these indicators of assessment, process, and outcome in standardized coding and embed it in documentation. And the assumption behind that is that if nurses and other professionals are documenting, even if you're using summative indicators for an assessment, a process, or an outcome, in fact, since it is a legal document, it is what they're doing. There is not a lot of fudging, although there is some research that shows that there are issues with documentation. So there are 3 types of translational research. The first one and third one I'm not going to talk about. Translational research, as at least I'm doing it and we're doing it in the clinical setting, is research that facilitates the movement between patient-oriented research and population-based research. Population health management and population-based research is relatively new. When we did the review of the literature for care coordination and transition management, there wasn't a lot in that literature in this area, but this is where we're going and this is where we need to go. For years, traditionally, we have looked at individualized care. Now we need to think of care as best evidence-based practice for patient populations, and then individualized care based on patient preferences and values. So it leads to better patient outcomes, implementation of best practice, and improved health status of communities. So what have we learned from practice with evidence-based guidelines and protocols? First of all, you can't always change practice. Secondly, you can't always enhance care outcomes. And third, they are difficult to sustain over time. They must be adopted. They must be fully integrated into the culture of a unit or an organization to be accepted over time. One of the things that helps to facilitate is that is the use of theory. And there are a lot of theories out there in acute care. The theory that I tend to use a lot and works fairly well in acute care is Everett Rogers' diffusion of innovation. And theory is a roadmap. It isn't an esoteric piece out, in the netherworld. It is a roadmap. And it provides the opportunity to do analysis of the context where evidence-based guidelines and protocols are being implemented. So it helps to identify contextual variables, beliefs, and attitudes. And I want to say a few words about attitudes because we got into a discussion a bit anyway earlier this morning about quality and safety in nursing education, CUSIN, the CUSIN Institute. CUSIN does define competencies. The definition of competencies in the literature is not great, and there's not a lot of consistency, but they have 3 types of competencies. They call them the KSAs. It's knowledge, skills, and attitudes. In what we've done with credentialing, we've focused heavily on knowledge and skills. I know from my practice, both as a researcher with translational research and as a facilitator, that attitudes drive practice. And the best example of that is hand washing and hand hygiene. Everybody has the knowledge as to why you wash your hands. We've known it since Semmelweis. We have the skills to wash your hands. Even kids in kindergarten can do it. Yet we have 60% compliance in healthcare. Why is that? It's all about attitude. I would also say, think about why we have continual issues with Claudy and CLABSI, central line infections and computer-associated urinary tract infections. It's all about attitudes. If you don't stay on them, there's slippage. So that's one piece. It helps to develop strategies to assist in controlling contextual variables, determining the dose and timing of interventions. We have a bad problem in healthcare. We assume if we teach somebody something once, they've learned it. And if you're an educator, you know that that's hardly the truth. It's repetition, repetition, repetition. And then delineating outcomes. Again, you look to the literature for outcomes and you look to what's really going on in practice as to what outcomes you want to follow. And then development of strategies for sustainability and strategies for diffusion, because we can't keep this information within the unit or within the organization. And that, again, is where standardized coding of indicators is important, because that makes the information shareable across units within an organization, across organizations, and across internationally with our global practice. So theory use and development offers a promising approach to understand the black box of implementation. This is Rycroft Malone's research and work. Within available evidence, issues include researchers do not pay enough attention to theoretical underpinnings. In nursing, much of our research until about 10 years ago, there was little said about theory. There was no theory driving the research that was going on. There's oftentimes, because of constraints in publication, not enough contextual details for assessment of transferability, and randomized controlled trials do not often go on long enough that, in fact, you get real understanding of the outcomes. You get short-term outcomes versus long-term outcomes and sequelae that were unexpected. So we have no clear directions for researchers, practitioners, or administrators in terms of implementation strategies to use, in which context, facilitated by who, with what groups of stakeholders, and what techniques to do and enhance sustainability. So when you think about translational science challenges, I'm saying let's look at translational science as a way of tracking the impact of credentialing. There are some challenges. The first of all is the issue of stakeholders, healthcare organizations. They are now really focused, and I can tell you in the last 5 years there's been a sea change in willingness of professionals across organizations, and I've done translational research in 2 large systems as a facilitator, a consultant, and it's a different world today than it was 5 years ago. There is a need to generate empirical outcomes to meet quality, pay for performance expectations, and magnet status and pathway status. There's issues with credentialed nurses as they are today, APRNs and nurses in specialty practice. Many masters and BSM prepared nurses were educated more than 10 years ago. And if they haven't kept up with their education, they know from nothing about evidence-based practice, and they will tell you that. They also have difficulty with population health management. Many APNs were taught to manage the individual. That's the focus of case management. And so consequently, they're very comfortable finding evidence to support the care of their individual patients. They're much less comfortable with working within a team to develop evidence-based protocols for that population of COPD patients or CHF patients. And then we have few APNs prepared at the DNP level, the Doctor of Nursing Practice level. And unfortunately, there's been recent research out of AACN in terms of the increased variability among programs for APNs. And so consequently, translational research is part of the essentials for DNP education. And yet I've presented at the AACN doctoral conference and had people ask me, what is translational research? And what texts are there for translational research? So we are in a sorry situation and not getting better fast enough. And there are still people recommending that we do evidence-based practice at the DNP level, where translational research is one of the defining factors of the DNP. So I know I'm saying, but I can say this because I'm an educator. So nurse educators are part of the problem, and they are educating in terms of evidence-based practice, but they went into this kicking and screaming. They were still teaching at the master's level how to do a research project, how to do a proposal, and this only changed, I think, with Pollitt and Beck's most recent book, because there was a lot of focus. So at the master's level, the change started to occur. And many are completely unaware of translational science. Also, traditional nurse researchers, to some extent, see translational science as second class. And they make this decision because the methods within translational science are different than, and they see as less rigorous than traditional research methods. Now, my response to them is, with translational science and translational research, we will generate larger data sets than you could ever do with traditional research, and they will be reliable data sets, and they will cross entire populations. There's limited expectations for translational science education. Unfortunately, it is only being done at the DNP level, whereas I work in hospitals and I have AD nurses doing translational science. And there's limited US translational science texts, literature, and experts. So the other challenge is the validity and reliability of data generated through documentation of processes and outcomes of translational holds great promise. And what I did with the process of developing the the care coordination and transition management, I was writing a chapter with Beth Ann Swan for Jerry Lamb's book that came out, the Game Changer, Care Coordination Game Changer. And I couldn't make head nor tails out of some of the literature on outcomes relative to care coordination. And so I said to Beth Ann, well, I'm going to do a logic model on this. And I don't know how many of you have used logic modeling, but logic modeling is extremely helpful for laying out assumptions and laying out expectations, but also laying out, and I laid out, what are the dimensions of care coordination that we've discovered through this process, and then laid out the activities for each dimension, and then laid out who should do it, and then what are the short, medium, and long-term outcomes of it. And what I discovered, I was doing this to figure out what I was going to write in this chapter, but the more I looked at this logic model, the more it dawned on me that this is the way that we can track not only who should be staffing ambulatory care for which populations, but also you can track credentialing, because Roy will probably tell you this is true. Within certain electronic health records, there is the capability, when signature is done by a professional, that triggers this professional, and it's based on scope of practice. If you can do that by what discipline are they in, you can also do it by what credential they have, if you also include that in the signature sign-off. So as I looked at this, I thought, oh my God, this is going to give us the information, because who can do it for most dimensions is physicians, nurse practitioners, nurses, social workers, etc. But as you look at this data repository over time and you see who's signing off for which dimensions, you begin to get a picture for what should staffing look like. So for certain patient populations, you're going to need more social work assistants, especially if they've got social determinant issues. And for other populations, you're going to need, in many cases, not even registered nurses, because they really don't need the dimensions of care coordination. The same is true for looking at credentialing and the contribution that that credentialed individual makes. So there are issues, though, with doing this tracking through electronic health records. Only 20%, we've heard this today, only 20% of healthcare organizations have fully integrated electronic health records. Many of the electronic health records do not have the internal architecture that will accommodate standardized coding of indicators. There is an absence or a lack of leadership understanding of the need for standardized coding. So the devotion of budget dollars to informatics is not there. In most places, you'll see it takes 6 months or more to get a screen created to follow data over time. And there are shortages of nurse informaticians, because they tend to understand what standardized coding is and why you would do it and how it fits with tracking assessments, processes, and outcomes. So if translational research and credentialing science, if it was done by credentialed nurses, we should accelerate movement between patient-oriented research and population-based research. We'd get better patient outcomes, evaluation of best practices, sustain best practices, and improve quality, safety, and health status. When you capture this data that's coded, you will get as I said, a very robust database in terms of process and outcome contributions. And it'll not only make a difference in terms of outcomes, but you also can support decision support development as a process also. So I am at my red light. so let me skip to, you can read those, but recommendations. I think we need to accelerate the pace at which nurse educators learn, appreciate, teach, and facilitate translational research in place of descriptive research. It is appalling to see the amount of descriptive research still being done. Foster nurse faculty practice as translational research facilitators so that they actually have the experience of doing it, can really teach it, and can really facilitate it. And expedite movement to the electronic health record internal architecture that supports across the board the standardized coding by producers and vendors. And finally, there was a lot of discussion about what should funding look like to support following and demonstrating the impact of credentialing. I believe that funding needs to start at the point of the informatics infrastructure and the informatics actually coding and the ability to actually track what nurses are doing. So thank you.